I mean, we're so used to the idea that more has to be better. How can
Yes.
it be harmful to go to another specialist visit? How can it be harmful to have a biopsy, get another scope, have an operation now that we've been able to lower the complication rates so much? And the answer that we're finding over time is that there's overuse of certain kinds of care that in marginal situations, the risks can still outweigh the benefits. We do have still major complication rates from surgeries and scopes and procedures. Second of all, uncertain tests lead to more tests, lead to more procedures, and we aren't seeing great benefit from it. And then the third thing is that masking that overtreatment, it often goes along with undertreatment of low-cost options for people.
I was going to say, how do you get people to engage in the less sexy, more preventative type approaches?
Yeah, I mean, the classic situation here is that we have a system that's pushing in multiple ways for doing more even when it may not be the right thing. Doctors point to the malpractice situation. Even bigger is that our revenues are greater when we do more and not when we try to deal with things like making phone calls and emails and trying to sort a lot of things out. And that can put pressure on time and how you make decisions. You also have the culture of what people expect. People come to you thinking, I should have an operation. I should have this drug that's on the ad. All of that put together pushes in the wrong way. I got a phone call from one of my family members, a cousin of my wife, who had this odd episode where he passed out and then seemed to be almost like a stroke. He got better in the hospital after a few days, thank goodness. They did lots of tests to understand what was going on. They found he had a low heart rate, very healthy guy. And he's known to have some periodic atrial fibrillation for which he takes a blood thinner. And so the thought was, well, the hospital cardiologist said you need a pacemaker. His longtime cardiologist had done monitoring and things before and had concluded he didn't need the pacemaker. And so he was asking me, what should I do? And it clearly is a gray zone case. Yeah. This is the classic situation. It's a little bit uncertain. Out of 100 patients in this situation, you wouldn't want all 100 to get a pacemaker, but 20 might be the right group to get it. And so I told him, the thing you really need is for your home cardiologist to talk to the hospital cardiologist on the phone and hear each other's reasoning and sort out a good plan together. But getting them together on the phone, people say, sure, but then what happens? They're too busy. No one can connect the dots. You don't get that thinking together. Chances are they would agree, I think, that he may not need that pacemaker, but he's likely headed towards having one for lack of getting that thinking together, and there's lots of reasons it pushes in that direction. So I think that's the fundamental thing we have to solve, and it's worse in some parts of the country than others. Right. We have sections of the country that cost twice as much per person, and it's to do with primarily doing lots more tests in those regions and more procedures. And we are finding over and over again now in multiple studies that the patients do worse under those circumstances rather than better. So, for an organization like Premier that's done so much to try to advance quality in hospitals, the hard part is that many of the decisions happen before the patient ever gets to the hospital. And what the organizations in Premier, the hospitals that are members, are suddenly finding they have to learn how to do is how to get their community of doctors to engage in this question of making sure the care is as appropriate as can be. And the answer to it is not necessarily set rules and algorithms, although there's some that really make a big difference. It's also not going to be anything that an insurance company or the government are going to provide the perfect rule. It's going to be much more collaboration and getting people to think together and take seriously the idea that we're bankrupting the country when we just assume the money is there for poor quality.
It's very interesting. I work for Premier, but I'm doing a project in the United Kingdom with the National Health Service and looking at where they are with primary care and prevention and whatnot. It's very interesting to me. And where do you think healthcare reform is going to take us in the U.S.? And do you think it's going to address these fundamental challenges that you've been talking about?
Yeah, I don't think it's heading us towards the UK for one thing. There's a serious problem of undertreatment.
Yeah.
And they're attacking it in various ways. But in our country, we are generally pretty good at making sure that people have good access to procedures and tests and so on. But making sure it's the right one, we're not good at that. And as individual doctors, it's very frustrating because you feel you have no power over the situation. Individually, we don't, but collectively, we do.
Right.
When we are able to get everybody from the primary physician to all the specialists to be able to manage the care, and that involves putting in technology, information technology that is hard for any one individual physician to do. And it also means non-technology stuff like picking up the phone and being able to reward people who do that. I think in every community you have these leaders who are quietly providing lower cost, higher quality care. And they are not the ones who win in those communities.
No, definitely not.
We have to be able to make it so that they are recognized, that their innovations are discovered, what they're doing differently, and then we spread the word of what they're doing.